Welcome to the deep dive. Today we're tackling a really intricate topic, the pathophysiology of the visual system.
It's definitely complex.
Our goal here is to break down Chapter 19, Disorders of Visual Function, from Porth's Essentials. We want to make it digestible, kind of layer by layer, from the eye surface right back to the brain.
And it's so important. I mean, the WHO estimates 161 million people worldwide are visually impaired. That's a huge number.
Wow.
Yeah, and a lot of that impairment comes from conditions we're going to talk about. So understanding how things go wrong is really the first step.
Absolutely. So the plan is, like you said, layer by layer. We'll start with the outer parts, the accessory structures, then move inside, talk about pressure, glaucoma, the lens, cataracts, the retina, and then finally how the brain makes sense of it all.
Sounds like a good roadmap. Let's dive in.
Okay, starting right at the surface. Eyelids. If you see someone whose upper eyelid is drooping, that's ptosis.
Right, ptosis.
Yeah.
And that immediately points to weakness in the muscle that lifts the lid, the levator palpebrae superiors.
Which makes you think about what controls that muscle.
Exactly. Cranial nerve the third, the oculomotor nerve. Or it could be part of something broader, like Horner syndrome, that classic triad, ptosis, constricted pupil, and lack of sweating on one side.
And then there are issues with where the eyelid sits. Entropion versus ectropion. They sound similar, but they're opposites.
Totally opposite effects. Entropion is when the lid margin turns inward, so the eyelashes are constantly rubbing against the cornea.
Ouch. Sounds irritating.
It is. Often happens with aging, sometimes scarring.
And ectropion.
That's the lower lid turning outward. Everting. Often linked to weakness in the facial nerve, CNCM. Here, the problem isn't rubbing, it's exposure. The eye dries out, tears spill over. Constant irritation again, but for a different reason.
Got it. Okay, moving from position to inflammation, the elapitis conditions. Let's quickly compare blepharitis, hordeolum, and chalazion.
Okay. Blepharitis is that chronic inflammation right along the edge of both eyelids, often linked to staph bacteria or seborrheic dermatitis, kind of crusty, itchy eyelids.
But the one people often mix up is the hordeolum, the stye, and the chalazion.
Right, and this is a key distinction clinically. A hordeolum, or stye, is an acute infection, usually staph. It's red, it's painful, think infection.
Okay.
A chalazion, though, is different. It's a chronic blocked oil gland, a meibomian gland. It presents as a firm, painless nodule in the lid.
Painless being the key word there.
Absolutely.
Yeah.
And not infectious. So antibiotics aren't the treatment. It's an inflammatory lump, not an active infection. That difference guides therapy completely.
Makes sense. And briefly, dry eyes. We need that tear film.
Yeah, that three-layer tear film, lipid, aqueous mucin, is vital. If it's unstable or deficient, you get dry eye symptoms. Irritation, burning, feeling like something's in your eye.
And if the tear drainage system gets blocked and inflamed?
That's dacryocystitis. Inflammation, often infection of the lacrimal sac, usually because the nasolacrimal duct is blocked. Leads to tearing, discharge, maybe some pain near the inner corner of the eye.
Okay, moving inward slightly. The conjunctiva, the clear membrane covering the white part of the eye. Conjunctivitis, or pink eye, is super common. Redness, itching, maybe some discharge.
Feels like sand in the eye sometimes.
Yeah.
But the really critical thing here for anyone assessing a red eye is knowing when it's just conjunctivitis versus something much more serious.
How do you tell the difference quickly?
Two main things: pain level and where the redness is worst. Simple conjunctivitis usually causes mild discomfort, maybe some grittiness, and the redness is more spread out, often worse in the periphery.
Okay.
But if you see moderate to severe pain, significant light sensitivity, maybe blurred vision, and the redness is really intense, right around the edge of the cornea, the limbus, that's a huge red flag. That suggests something like acute glaucoma or keratitis, a corneal issue, needs urgent attention.
Good distinction. And sometimes with allergies, you see that cobblestone look under the eyelid.
Exactly. That papillary hypertrophy is classic for allergic conjunctivitis.
Yeah.
Okay, let's look at cornea, keratitis.
Inflammation of the cornea. You mentioned it's a vascular, right? No blood vessels.
Right, and it has this protective layer, the Bowman membrane. If that gets damaged, it scars, and because it's a vascular, healing is tricky, and scars tend to be opaque. That means vision loss.
What are the big causes of keratitis we need to know?
Well, herpes simplex virus is a major one. HSV keratitis is actually a leading cause of corneal blindness worldwide. Usually affects one eye, and you might see this characteristic branching like a little tree branch pattern on the cornea if you stain it.
Okay, HSV. What else?
Xanthomeba keratitis. It's rare, thankfully, but really serious. Strongly linked to contact lens use, especially exposure to contaminated water, tap water, hot tubs, swimming pools.
What's the key sign there?
The absolute classic sign is pain that seems way out of proportion of what you actually see on the cornea. If a contact lens wearer has severe eye pain, but the eye doesn't look that bad initially, you have to suspect a xanthomoeba. It's an emergency.
Wow, okay. Pain out of proportion. Got it. Let's shift gears now from infection and surface issues to internal pressure. Glaucoma. You called it the silent thief of sight.
It really is. Because it often develops so slowly, people don't realize they're losing vision until it's quite advanced, and it's a leading cause of irreversible blindness.
So what's happening mechanically?
It's fundamentally an optic neuropathy damage to the optic nerve. This damage happens because the fluid inside the eye, the aqueous humor, isn't draining properly.
It's made by the ciliary body.
Right, and it's supposed to flow out through this meshwork, the trabecular meshwork, into the canal of Schlemm. In glaucoma, that outflow is impaired. So fluid builds up, pressure inside the eye, the intraocular pressure, or IOP, rises above the normal range, which is typically 9 to 21 millimeters of mercury.
And that pressure squeezes the optic nerve.
Exactly. It compresses the nerve fibers and the blood vessels supplying them, leading to progressive atrophy, or wasting away, of the nerve. You can actually see this when looking at the back of the eye. The optic cup, the center part of the optic disc, gets larger.
Okay, so there are different types. The main one is primary open-angle glaucoma.
Yes, that's the most common form. Open angle means the physical angle between the iris and the cornea is open. It looks normal. The blockage is microscopic down in the trabecular meshwork itself. It's just not draining efficiently.
And the danger is that it's slow and silent.
Precisely. It's usually chronic, progressive, and asymptomatic in the early stages. People lose peripheral vision first, very gradually, so they also don't notice until significant permanent damage has occurred. That's why screening, especially for those at higher risk, older age, African ancestry, family history, is so critical.
Then there's the opposite, angle-closure glaucoma. That sounds more dramatic.
It is. It's an ophthalmic emergency. This happens in people who are anatomically predisposed. They have a naturally narrow angle where the iris meets the cornea.
So the drain is already in a tight spot.
Exactly. And if the pupil dilates, say, in dim light, or due to certain medications, the iris can bunch up and physically block off the trabecular meshwork completely. It's like slamming a door shut on the drain.
And the pressure skyrockets.
Very quickly. Symptoms are sudden and severe.
Yeah.
Intense eye pain, headache on that side, often mistaken for a migraine, blurred vision, seeing halos or rainbows around lights, nausea, vomiting. The pupil might be fixed in a mid-dilated position. This needs immediate treatment to lower the pressure and save vision.
Okay, let's move on to how the eye actually focuses light onto the retina. Refraction, that's the bending of light rays, right? Mostly by the cornea, then fine-tuned by the lens.
Exactly. And refractive errors happen when the light doesn't focus perfectly on the retina, usually because the shape or length of the eyeball is a bit off or the cornea's curve isn't quite right.
So myopia, nearsightedness, what's the issue there?
With myopia, the eyeball is typically a bit too long or the cornea is too curved, so the light from distant objects focuses in front of the retina, not on it. Close-up vision is fine, but distant objects are blurry.
And you fix that with a concave lens, one that spreads the light out a bit before it hits the eye.
Correct. Hyperopia, or farsightedness, is the opposite. The eyeball is too short, or the lens cornea system isn't powerful enough. Light focuses theoretically behind the retina.
So distant vision might be okay, especially when young and the eye can accommodate, but near vision is blurry.
Right. And you need a convex lens, one that converges the light rays more strongly to correct it.
Then there's the one that gets almost everyone eventually, presbyopia.
Ah, yes, the my arms are too short syndrome. Presbyopia isn't really about the eyeball length. It's an aging change in the lens.
It gets harder, less flexible.
Exactly. The lens loses its elasticity over time, and the ciliary muscle might weaken a bit too. This means the eye loses its ability to accommodate, to change focus for near objects. That's why people start needing reading glasses, typically in their 40s.
Makes sense. Now let's talk about the lens itself becoming cloudy. Cataracts.
Cataracts are simply an opacity or clouding of the normally clear lens. This interferes with light reaching the retina. It's the most common cause of age-related vision loss globally.
Besides aging, what else increases risk?
Oh, several things. Long-term exposure to UV light, diabetes, smoking heavily, certain medications like corticosteroids, previous eye injury or surgery.
And how does it affect vision? Just blurriness?
Blurriness and decreased visual acuity are common, yes. But a really prominent symptom, especially with certain types of cataracts, is glare. The cloudy lens scatters the incoming light, causing significant glare, halos around lights, difficulty seeing in bright sunlight or driving at night.
That makes sense. Now, there's a critical point about cataracts in babies' congenital cataracts.
Yes, absolutely critical. If an infant is born with a cataract that's dense enough to block vision, it must be removed surgically very early. The textbook often says by around 2 months of age.
Why the extreme urgency?
It's all about preventing amblyopia. The first few months and years of life are a critical window for visual development. If the brain doesn't receive clear images from an eye because of a cataract, the visual pathways for that eye simply don't develop properly.
So even if you remove the cataract later, the brain can't process the information.
Exactly. The eye might be physically fine after surgery, but the brain connection is permanently impaired, leading to lazy eye or amblyopia. Early removal allows that pathway to develop. It's sight-saving.
Okay, we're deep inside the eye now. The retina, the light-sensitive tissue lining the back of the eye, like the film in a camera. What's a key thing to remember about retinal diseases?
A really fundamental point is that the retina itself lacks pain fibers. So most diseases affecting the retina are painless, even when they're causing significant vision loss.
That's crucial. Pain isn't usually the warning sign here. Let's talk about diabetic retinopathy, a huge issue.
Absolutely. A leading cause of blindness in working-age adults in developed countries. It basically comes in 2 main stages.
First is background or non-proliferative retinopathy. What's happening there?
This is the earlier stage. High blood sugar damages the tiny blood vessels in the retina. They start to leak fluid or blood, forming little outpouchings called microaneurysms and small hemorrhages. You might also get swelling in the central part of the retina, the macula.
Macular edema.
Yes, and that macular edema is actually the most common reason people with non-proliferative diabetic retinopathy experience decreased vision. The swelling blurs that crucial central site.
Then things can get worse, progressing to the proliferative stage.
Right. This happens when the retinal damage leads to poor oxygen supply or ischemia. The eye tries to compensate by growing new abnormal blood vessels. That's called neovascularization.
Proliferative meaning growing new stuff.
Exactly. But these new vessels are bad news. They're fragile, they bleed easily into the vitreous, the jelly filling the eye, which can suddenly cloud vision. And worse, they often grow with fibrous scar tissue, which can contract and pull on the retina.
Killing the retina sounds like that could detach it.
Precisely. That traction is a major cause of retinal detachment in proliferative diabetic retinopathy, which brings us to retinal detachment itself.
So detachment is when the retina physically separates from the layer underneath?
Yes, the neurosensory retina pulls away from the retinal pigment epithelium, or RPE. This is bad because the RPE and the underlying choroid supply vital oxygen and nutrients to the photoreceptors. Detachment cuts them off.
Is there a common way this happens?
The most common type is called regmatogenous detachment. Regma means break or tear. What usually happens is the vitreous jelly inside the eye changes with age, liquefies, and shrinks. As it pulls away from the retina, it can create a tear.
And fluid gets under the tear.
Exactly. Fluid from the vitreous cavity seeps through the tear and gets behind the retina, peeling it off like wallpaper.
What would someone experience if this happens?
It's often quite dramatic, though usually painless. People might first notice flashing lights or sparks, often in their peripheral vision. Then, a sudden shower of floaters, little specks or cobwebs drifting in their vision. And then, classically, the perception of a shadow or a dark curtain starting at the edge of their vision and progressing across. It's a true ocular emergency.
Okay. Flashes, floaters, curtain. Got it.
All right.
Let's cover one more major retinal issue, age-related macular degeneration, or AMD. This affects central vision, right?
Yes, AMD specifically targets the macula, the small central area of the retina responsible for sharp, detailed vision, which you need for reading, driving, recognizing faces. Big risk factors are age, smoking, and it's slightly more common in women.
And there are 2 types, dry and wet?
Correct. The dry form or non-exudative AMD is much more common, maybe 85–90% of cases. It involves the gradual breakdown of cells in the RPE and the accumulation of these little yellow deposits called drusen under the retina. Vision loss is typically slow and gradual.
And wet AMD?
Wet or exudative AMD is less common, but generally more severe and progresses faster. It's characterized by the growth of abnormal, leaky blood vessels from the choroid under the retina, a choroidal neovascular membrane.
Similar to proliferative diabetic retinopathy, but coming from underneath.
Kind of, yes. These vessels leak fluid and blood, causing swelling, scarring, and often rapid and severe loss of central vision. This is where treatments like anti-VEGF injections are often targeted, trying to stop those leaky vessels.
All right, we've captured the light, converted it to signals. Now, how do those signals get to the brain and get interpreted? We need to talk about the optic pathways.
Okay, so the optic nerve fibers from each eye travel back and meet at the optic chiasm, just under the front of the brain.
And this is where that crucial crossing over happens.
Exactly. The fibers from the nasal half of each retina, the half closer to your nose, which sees the temporal or peripheral visual field, cross over to the opposite side. The fibers from the temporal half of each retina stay on the same side.
Why is that crossing pattern so important?
Because it determines the pattern of vision loss when there's damage along the pathway. Lesions at different points cause very specific visual field defects.
Okay, let's use the terminology anopia.
Blindness in one eye usually means damage to the optic nerve before the chiasm.
Hemianopia.
Loss of half of the visual field, and the pattern tells you where the problem is. For example, if there's a lesion right at the optic chiasm, maybe a pituitary tumor pressing on it, what gets damaged?
The crossing fibers, the nasal fibers from both eyes.
Right, and since those nasal fibers see the temporal fields, you lose the outer peripheral vision in both eyes. That's called bitemporal hemianopia, like wearing blinders.
Okay. What if the damage is after the chiasm, say in the optic tract or further back?
Well, after the chiasm, each optic tract contains fibers from the same half of the visual field from both eyes. For example, the left optic tract carries info from the right visual field of both the left eye and the right eye.
So a lesion there causes
Homonymous hemianopia. Homonymous means the same side. You lose the same half, either the right half or the left half of the visual field in both eyes.
That makes sense. It's all about tracing where the fibers go. What about problems in the brain itself, the visual cortex?
If you have destruction of the primary visual cortex, area 17, in the occipital lobe, say from a stroke affecting both sides, you get cortical blindness. The eyes might be perfectly healthy, the pathway is intact up to that point, but the seeing part of the brain is gone. No conscious visual experience.
Can anything be more subtle?
Absolutely. Damage to the visual association cortex, areas 18 and 19, can cause visual agnosia. This is fascinating. The person can see perfectly well, they can perceive colors, lines, shapes, movement.
But they can't recognize what they're seeing.
Exactly. They might describe an object in detail, it's long, yellow, curved, you eat it. But they cannot name it as a banana just by looking. The link between the visual input and its meaning or identity is broken. It's a failure of recognition, not of seeing itself.
Incredible. Okay, last piece. Coordinating the eyes, strabismus and amblyopia.
Strabismus is simply misalignment of the eyes. A squint or crossed eyes. One eye might turn inward, esotropia, outward exotropia, upward hypertropia, or downward hypertropia.
And the immediate problem that causes, especially in adults or older children, is
diplopia, or double vision. The brain is receiving two different images and can't fuse them.
But in young children, the brain adapts differently, leading to amblyopia.
Yes, and this is arguably the most critical concept in pediatric ophthalmology. Amblyopia, or lazy eye, isn't lazy at all. It's decreased vision in one eye, or sometimes both, because the brain didn't learn to see properly with that eye during early childhood.
What causes the brain to ignore an eye?
Two main things we've touched on. One is visual deprivation, like that congenital cataract blocking a clear image. The other is strabismus. If the eyes are misaligned, the child would see double. To avoid this, the brain actively suppresses or ignores the input from the deviating eye.
And if that suppression goes on long enough during that critical developmental window,
the visual pathway for that eye essentially gets shut down, leading to permanently reduced vision, even if the eye itself is structurally normal.
So the takeaway is early detection and treatment are key.
Absolutely paramount. Amblyopia is often treatable, usually by patching the good eye to force the brain to use the lazy one, or by correcting the underlying cause like strabismus or refractive error. But treatment is most effective before about age 6 or 7. After that, the visual system is less plastic, and the vision loss can become permanent. #Nablatro.
Wow. Okay, we have really gone from the front to the very back, haven't we? From itchy eyelids with blepharitis all the way to the brain, failing to recognize objects in visual agnosia. It's incredibly complex.
It really highlights how many different things need to work perfectly for us to see clearly. From tear film stability to fluid drainage, lens clarity, retinal health, nerve transmission, and brain processing.
Yeah, any glitch along that chain can cause problems.
And maybe that brings us to a final thought, connecting back to amblyopia and congenital cataracts. Given how crucial that early developmental window is, it really underscores the importance of routine vision screening in infants and young children.
Things like checking the red reflex in newborns.
Exactly. Simple checks like that can pick up potentially blinding but treatable conditions like cataracts or even retinoblastoma incredibly early. And screening for misalignment or refractive errors before school age can catch and treat amblyopia while it's still reversible. It's all about catching these things early to prevent potentially lifelong avoidable vision loss.
A really powerful point about prevention and early intervention. Excellent synthesis. Thank you so much for walking us through all these layers of visual pathophysiology.
My pleasure. It's complex stuff, but hopefully breaking it down helps.
We certainly hope this deep dive helps you solidify your understanding of this vital sensory system. Thanks for joining us.